Hello everybody, my name is Raghu Kataru. I am an assistant lab member at Department of Surgery, Memorial Sloan Kettering Cancer Center, New York. First, I want to thank the CLF and the organizing committee for this opportunity. Today, the title of my talk is Obesity and Secondary Lymphedema. I have no disclosures. Before going into the discussion of secondary lymphedema, I want to give a brief introduction of lymphatic system and organization. Lymphatic system is blind-ended circulatory system that runs along the blood vessels and helps in the body fluid homeostasis. It is organized as a network of initial capillaries that absorbs and drains into larger collecting vessels covered with lymphatic muscle cells. These muscle cells and lymphatic collecting vessels help in lymphatic pumping. Fluid from the collecting lymphatic vessels drains into lymph nodes and subsequently to systemic circulation, thus maintaining body fluid homeostasis. Here on the right is an image of fluorescent dextran lymphangiography of mouse ear skin showing a network of the initial lymphatic vessels, the collecting lymphatics, the draining from the initial lymphatics, and the draining lymph node here with a fluorescent dextran in single frame. So what is lymphedema? But frankly, as we reach the end of this conference, I believe all of you are aware of what is secondary lymphedema from the previous wonderful talks. But in majority cases in the Western world, secondary lymphedema develops after lymphatic injury in patients who undergo lymph node dissection for cancer treatment. But in our cases, we are always intrigued how an injury in the axilla leads to lymphatic abnormalities in the entire limb, not just in the axilla. Our research over the past decade led us to understand the major pathophysiological changes happening in lymphedema and how chronic inflammation, especially Th2 T cell inflammation, that is Th2 Th2 T cell inflammation, is at the center of these pathological changes. But today, most of my focus will be on obesity, adipose deposition, how they are linked to lymphedema, and of course, last few slides I will talk about epidermal changes that's happening in lymphedema. Lymphatic system and adipose tissue are closely associated. So as you can see from these beautiful photographs, even in normal physiology, lymphatic system is closely and physically associated with adipose tissue. Dietary lipids, the lipids that we consume through our diet, are absorbed in the intestine by intestinal lymphatic vessels called lacteals in the intestinal villi. These absorbed lipids are transported through lymphatic system. As you can see from this image on the left, the transparent afferent lymphatic vessels running in the middle of dense adipose tissue uh, shown in these arrows. On the right again, the blue color lymph node, uh, it's blue colored because I think the mouse was injected with the Evans blue dye that reached the lymph node. The blue color lymph node is surrounded by thick fat pads. So this close association of lymphatics and the lymphatic system doesn't surprise us that both adipose tissue and lymphatic system are interconnected during pathophysiological conditions, especially related to lymphatic vessels like lymphedema. Lymphedema cause adipose deposition. Early stages of lymphedema are characterized by fluid accumulation in the subcutaneous tissues, as you can see in this image on the left. However, as the disease progresses, there is a chronic fibrofatty tissue accumulation, and subcutaneously as shown in the image on the right. This is a late stage image of a patient. You can clearly see the leg with the lymphedema, accumulation of fibrofatty tissue indicating lymphedema caused adipose deposit. The question is, how does it happen? Does lymphatic fluid cause adipose deposition? Yeah, that's the important question, and the evidence suggests that evidence from the research suggests that this is due to proliferation of adipocytes caused by lipid-rich lymphatic fluid. In seminal experiments by Natasha Harvey from Australia, um, they found that when pre-adipocytes cultured in lymph, they end up differentiating into lipid-rich adipocytes, indicating lymph is adipogenic. Here you can see pre-adipocytes on the control media on the left media versus the same cells cultured in the lymphatic fluid. You can see that the cells cultured with lymphatic fluid, they are stained with the red color lipid stain, oil radio staining, showing that there is the cells accumulated lipids that are cultured with the lymph fluid. This experiment indicates that lymph fluid is adipogenic, and in a condition of lymphedema, when tissues are bathed in the lipid-rich lymph in lymphedema patients, the fibroblasts or pre-adipocytes take up the lipids from the lymph and become adipocytes and cause fat accumulation, as we have seen in the previous slide. We have also found that IL-6 expression is increased in lymphedema, and it actually regulates adipose deposition. It is increased in the serum and lymphedematous tissues of patients with lymphedema. Using transgenic mice that actually lack inflammatory cells like T cells, we actually found that depleting CD4 T cells with antibodies has shown that this response is downstream from T cell inflammatory reactions and serves to decrease adipose tissue deposition. Interactions between lymphatics and obesity is bidirectional, especially in pathologies like lymphedema. It turns out that interaction between lymphatics and obesity is bidirectional. So, not only does lymphatic dysfunction cause obesity or fat deposition, a lot of evidence suggests that obesity can also injure lymphatics. Indeed, patients who morbidly obese can spontaneously develop lymphedema, as you can see from this study showing dermal backflow and decreased lymph node uptake in the patient from these morbidly obese patients. The lymphedema is spontaneous. Also, obese patients have a much higher risk of developing lymphedema, and studies showed that weight loss has been shown to be effective in decreasing the severity of lymphedema. In our laboratory, using animal models, we have found that obesity similar to lymphedema results in development of leaky lymphatics and decreased pumping. These are some of the ears skins injected with a dye, colored dye, Evans blue dye. Shows a normal looking lymphatic network in the lean animals, but obese ears are highly leaky. As you can see, the dye is leaked out of the lymphatic network, and it is in the interstitial spaces. In fact, our research also found a linear relationship between mouse weight and the frequency of lymphatic pumping of the collecting vessels. And more importantly, we found that these adverse effects of obesity on lymphatics are reversible with weight loss or exercise. The graph on the left shows increased lymphatic pumping frequency in weight loss animals compared to obese animals, and the number of pumps per minute are quantified and the graph on the right. As you can see, with the weight loss, the pumping is much more strong, the number of pumps per minute increase compared to obese. Of course, the lean animals have normal lymphatic pumping. So based on our research, uh, we found that obesity and lymphatic dysfunction work in feed-forward manner, and as I explained before, weight loss and aerobic exercises prevent lymphatic dysfunction caused by obesity and might decrease the propensity for secondary lymphedema. Now we switch on to quickly switch on to some of the our recent work on what are the epidermal changes that we have observed in lymphedema. Hyperkeratosis is the key histologic feature of lymphedema. Please note that the increased epidermal thickness in this patient's skin compared to the normal skin in these H&E images, indicating there is a severe hyperkeratosis and epidermal thickening in lymphedema. But how are these keratinocytes are proliferated in lymphedema? Based on our research, we know that Th2 cytokines such as interleukin 4 and interleukin 13 are needed for differentiation of CD4 T cells into Th2 phenotype, and these Th2 cells cause lymphatic dysfunction, fibrosis, and decrease lymphangiogenicis. So we applied this concept in phase 1 clinical trial with patients with breast cancer related lymphedema. This was an open label single arm study in which patients were treated with monthly injections of IL-4 and IL-13 neutralizing antibodies for 4 months, followed by a 4-month washout period. We were disappointed that at the end of the treatment there was no effect on arm volume. However, interestingly, we did see a significant decrease in the degree of skin stiffness as measured by a skin tonometer. The graph on the right shows the skin stiffness values. Is significantly the stiffness of skin significantly decreased in patients that were treated with IL-4, IL-13 blocking antibodies. And more interestingly, this Th2 blockage decreased epidermal thickness. Uh, we got using the biopsies obtained from the normal arm and the lymphadematous arm before and after treatment. We found that blockade of IL-4, IL-13 significantly decreased the thickness of the epidermis and decreased the expression of keratin 14, a marker that is usually only expressed in the basal layer of the epidermal cells. I mean, these images you can appreciate such differences in keratin 14 expression before and after IL-4, 13 blocking antibody treatment uh, in the related, and of course the related quantification is shown below. What we found is proliferated keratinocytes produce Th2 inducing cytokines. We saw hyperkeratosis, there is increased proliferation of keratinocytes, but not only that, these keratinocytes are a major source of Th2 inducing cytokines like TSLP and interleukin 25. These cytokines promote Th2 differentiation, and this effect was decreased when we block with IL-4, IL-13 antibodies. This finding is interesting as it suggests that keratinocytes may actually play a role in the pathophysiology of lymphedema, and that's an area that we are actively investigating currently in our laboratory. So in a nutshell, after lymphatic injury, CD4 T cells infiltrate the injured tissue, and these T cells secrete IL-4, IL-13 that help differentiate these T cells into Th2 type cells, and these Th2 type T cells have adverse effects on lymphatic vessels, leading to accumulation of edema, fibrosis, and adipose deposition. And our preclinical research showed that depletion of CD4 T cells or blockade of IL-4, IL-13 or targeting fibrosis can stop the pathological cascade of that inhibit lymphedema. Importantly, relevant to this talk is Obesity predisposes patients for the pathology of lymphedema, as obesity helps in all these different processes of these pathological steps that are involved in lymphedema. In under conclusion, pathophysiology of lymphedema is complex. It includes chronic inflammation, especially the Th2 type inflammation. And of course, obesity and lymphatics are intimately related in normal physiology, and especially in pathology like lymphedema. They function in a feed-forward manner where obesity affects causes lymphatic dysfunction, and lymphatic dysfunction in turn causes obesity. And our recent research also show that keratinocytes may play a role in lymphedema development and progression. I want to thank our director, Dr. Babak Marara, for his support in all aspects of the research, and the current and the previous lab members who did a wonderful job in the lab. We want to thank Dr. Dayan and Dr. Roxanne for their collaboration, and of course, all our grant support. Thank you very much for your attention.
Thank you for being here at this session where we'll reflect on a more macro problem of obesity-related lymphedema in Canada in particular, but it is an issue worldwide. So Marie-Ève Letellier did the literature review for this presentation, and neither of us has a conflict of interest to declare. So this is the problem. Now, I was trained, and I am a palliative care physician, and this is a palliative situation. And when faced with a palliative situation, we have to ask ourselves, what are the causes? And in the roles that we assume as health professionals, we also have a role of advocate. So the reflection here is, what is it in my role as advocate and as teacher that I should be doing as educator to help at least stabilize the problem and ultimately reverse it in our communities. So obesity-related lymphedema is a significant problem. And as we'll demonstrate, it's still very much under-recognized and under-treated. This is the CLF prevalence calculation. And you'll see that class 3 obesity is the commonest cause of lymphedema in Canada. And most health professionals are not aware of this fact. So how does it happen? Well, it's still being studied. It's been studied in animal models, and increasingly we're beginning to understand, but there's a lot of basic science work that still needs to be done. There's a dynamic overload of the system, and also there's an impact on the venous circulation that causes initially a dynamic insufficiency where the lymph scintigraphy will be normal, although the lymph transport system is overwhelmed. And when the lymph transport system is overwhelmed for a long period of time, and how long is that? It could be 6 months, a year, 2 years, but eventually it's going to fail and lead to lymphedema. So unfortunately, the rates of obesity in the world are increasing, and this is the WHO now being involved and mapping out strategies for us to counter this worldwide epidemic. So you'll see here the rates in the US, the rates in Canada, all going up. And Europe is very much like Denmark here, around that figure. And the lowest rates are in countries like Vietnam and Japan. Now, normally when we assess the problem, we look at BMI. When we see BMI, we have to understand that those prevalence rates are determined by asking people what their height and weight are. and they are underestimates of the problem. So please check to see if you have corrected figures when you see population statistics on BMI. But as colleagues in the Public Health Institute of Quebec are telling us, we should be looking at waist circumference really when we look at the impact of comorbidities related to obesity and the waist to height ratio, for example. And if we look at that in our own community, so my own province is Quebec, for example, but please do the exercise and look it up in your own community. We see that using waist circumference, half of women are obese and a third of men, and the rate has doubled since 1990. Now, I used to be a strong advocate of tobacco legislation in my past, and now we see that obesity may soon overtake tobacco. As far as cancer, being responsible for cancer incidence is concerned. So this is the same information from Quebec presented more graphically, showing that across all age groups, the rate of obesity is increasing. In terms of obesity and cancer, I think more and more people are aware that obesity is a major cause of cancer and increases the rate of developing cancers by up to 50%. One thing that should concern us is obesity amongst adolescents and children. So the rate is high. Now, even if it stabilizes at this level, these are children that will grow up to be adults who will tend to be obese. So we're going to have work for the foreseeable future in dealing with this problem. In spite of all that, try Googling comorbidities associated with obesity. And you're going to find charts like this that have all the standard well-known comorbidities related to obesity, but nowhere will you find chronic edema, lymphedema, cellulitis as a complication of obesity listed on these graphs. So what we need to do is to educate our communities, educate our health professionals so that lymphedema, chronic edema, and its complications are also on these lists that are being taught and disseminated. What's happening to treat obesity? So I attended the Obesity Canada conference earlier this year, and there are many novel drugs being discussed. Very interesting, no doubt, expensive, many of them. So these are drugs that people need to be on. What happens when the drugs are stopped? Well, the obesity will likely come back. So these novel drugs, it's good to have them, but is it the solution? Is bariatric surgery the solution, to have our stomachs operated on, or bypasses? Is this the solution? Is this the way we want to live as a society? And what many people don't understand is once obesity becomes established, then diets and exercise have limited effectiveness. And there are genetic factors and metabolic factors that make it basically an irreversible condition once it's established. What is the risk of developing lymphedema when you're obese? So Green, Sudath in Boston have some good recent articles about this, and we'll reference them at the end. And this is the, according to BMI, this is the rate of lymphedema, chronic edema. Now, these rates might be actual underestimates because they're based on lymphoscintigraphies. And as I explained earlier, someone can have a problem and yet the lymphoscintigraphy can be normal in the early stages of this problem. So we know that once obesity is established, it's hard to get rid of it. What about the lymphedema? Well, you can be obese, have lymphedema, and then you lose weight, say from bariatric surgery, and the lymphedema is not going to respond as well as other conditions such as diabetes, hypertension, and may in fact not be reversible. And this is the way Green would put it. So this is the issue. And since weight loss will not have a significant impact on the lymphedema once you've gotten to late stage 2, stage 3, many of these people, by the time we see them, they're at stage 3, then what we want to ask for in the history is the maximum BMI. So what's the highest weight you've ever had? Or at least what was your weight 5 years ago? Because just because they're slimmer today doesn't mean that, especially if it's post-bariatric surgery, we want to know what their maximal weight is. And this is an image of what we see. This is obviously stage 3, very advanced. And then they may have these localized areas of lymphedema known as massive localized lymphedema. What about cellulitis? We know that the rates of cellulitis in this population are higher than the rates seen in those with cancer-related lymphedema. So diagnosing them early, treating them early, trying to prevent the progression of the lymphedema will reduce the risk of cellulitis. And there's a good Australian study that we reference here just to talk about the remarkable decrease in cellulitis that you see when you treat these people with compression and other elements of decongestive therapy. So in summary, what are the issues? Well, these patients are not diagnosed, or they're diagnosed very late. The other thing in this population is our decongestive lymphatic therapies are less effective compared to the cancer population. And if you don't treat the obesity, then you're not going to have much success at all in treating the edema. It's hard for these people to find suitable compression solutions. It's hard for them to do the self-management. They get more recurrent cellulitis and wounds as well, and the sepsis. And the comorbidities associated with obesity impact function, so they interfere with the success of decongestive therapies. So if you go at a more macro level, what can we do in our communities to improve the health of the community? And I would suggest to you that we do need a public health approach, just as we had to do with tobacco. And the WHO does have a plan for this, and we just have to push our legislators to do something about this, as well as the many other problems that we're facing in society right now. And on an individual level, what can I do today? What can I do this week for myself, for my family, children, grandchildren? As professionals, we need to educate our peers, especially those in primary care, about this problem. We need to promote the training of professionals in the community that can guide others in appropriate prevention, diagnosis, and treatment. And perhaps the person to do that would be the nurse who's a wound care professional, as well as being lymphedema trained. And we would need new appropriate courses to form that kind of professional. So in summary, we need to advocate to prevent obesity. We need to educate obese patients so they don't develop lymphedema. And if they do, we need to diagnose and treat it early. And yes, just to encourage us to try and do something, even if it seems small, to try and counter these problems that we face. And this would be the recommended references. Thank you very much.